So if you notice in your goodie bags, did everybody get a swag bag? They're in the back if you haven't received yours. So thank you to our sponsors and everyone who donated for that. Again, there's some wonderful stuff in there. Also in there is you guys get the first peek at the first chapter of the new Menopause. Feel free to take pictures, share this on social media. It is available for pre-order everywhere you buy books. You want to read out a segment to your followers, that's fine too. We would love, this is from the heart. I wrote this book for you. I wrote this book because you asked me to. I wrote this book, Galveston Diet is still doing great, but it wasn't enough. We really had to do a much deeper dive into menopause, and your questions informed me. Why did 10,000 women reach out to me about frozen shoulder? And then of course, Dr. Wright, thank God, has been able to help so many of us. And why did, tinnitus and vertigo and all these things that are so, and mental health disorder, and so all of this book was informed by your questions, things I did not know that we weren't trained about. So I'm gonna step down and we're gonna have our first panel of the day. Let's get this show on the road. So let me bring up Anne Fulenwider. I'm trying to pronounce that correctly. She says full and wide, just like after Thanksgiving, from Alloy Health. So she's gonna be emceeing our first panel. So I'm gonna switch this.
Test, 1, 2. Oh, no, that one stays there. That one's...
Oh, she's got one. Okay.
You got your own personal mic.
Thank you. Thank you so much to Mary Claire. Let's just give her a huge round of applause for this entire thing. I will be really quick. I told a lot of you last night we are a digital women's health company addressing the needs of women over 40 in perimenopause and menopause. I also told you we believe women over 40 deserve to feel fucking fantastic, which we say a lot, but what we also say is we see you, we hear you, we are you, because my co-founder and I founded Alloy because we could not find the solutions that we were looking for. And I've heard a lot of you, not even 24 hours in, have had the same experience. And so I'm just so grateful to all of the experts here, so thrilled to be here. And want to thank you all. Really quickly, Alloy is a website, myalloy.com. You go on, you enter your symptoms. There's tons of information, medically vetted information by experts. You type in your symptoms and your medical history. We'll match you with a doctor who is licensed in your state. And we're in 50 states. And as of next week, I think we're in Puerto Rico, which is great. And then you and that doctor come up with a treatment plan. You decide what you want and what you don't want. And then we ship you your medication in this cute little bag. There is a symbiotic in your bag, but other than that, all of our solutions are hormonal. So we do HRT, we do vaginal estrogen cream, and we've just moved into sexual health and skincare. So we have a estrogen-based face cream. You might have seen Mary Claire post about it. And we also have an orgasm-enhancing cream. So check it out. And now on to the experts. I want to bring up my panel. Dr. Corinne Menn, Dr. Vonda Wright, and Dr. Kate White. Where are you? Okay, so these guys, I could spend the whole 45 minutes giving you their credentials. It's amazing. We're here to talk about the myths of menopause, but just because we're the first panel, I really want to give you a sense of the depth of the expertise. So I'm going to go a little bit deep into their bios. I have like my entire school bag here. And then we'll go, I'm just going to ask them a couple of questions, then we're going to go straight to your questions, okay? And Jamie's there to remind me of my time. Dr. Kate White in the middle. Dr. Kate White is a board-certified menopause and sexual medicine specialist with 25 years of managing and treating menopausal symptoms and specializing in sexual medicine. She cares for it, She cares for and educates women through her practice at Low Country OBGYN in Charleston, South Carolina, and at the nail salon, and in the line at Target, and anywhere there is a woman who wants to listen. When she realized that her patients needed much more than her residency training had prepared for her in the area of menopause and sexual medicine, she sought out the top thought leaders in those areas of ISSWISH and NAMS, those are the professional organizations, and now she makes it her mission to spread the word every day. She has a medical degree from the Medical University of South Carolina. Her residency was at the University of Texas Medical Branch, where she came to know and love Dr. Mary Claire Haver. You can tell I'm a New Yorker, I'm speaking really fast, but I want to get through this stuff because it's really unbelievable, the level of expertise and the access that we have to these experts. Dr. Corinne Menn is a medical advisor and prescriber at Alloy. First line of her bio, in my opinion, but she's also a leading expert on menopause management, the unique female health concerns of cancer survivors, and pediatric and adolescent gynecology, and preventative care and wellness. A sought-after speaker and clinician, Dr. Menn focuses on areas she feels are not often well addressed or afforded to the time of patients of many OBGYN patients. A breast cancer survivor herself, Dr. Menn was diagnosed at just 28 in the middle of her OBGYN residency, giving her not just the medical knowledge and expertise, but the empathy and understanding that can only come from someone who's been there. Dr. Menn takes an inclusive approach to healthcare and believes in incorporating nutrition, fitness, and mind-body medicine in her treatment plans for patients. Investigating the root causes of female health problems is the goal, rather than just treating symptoms. Using evidence-based medicine, Dr. Menn incorporates traditional and complementary approaches to care. And lastly but not least, just third on my list and right next to me, is Dr. Vonda Wright. At 40, Dr. Wright was in the best shape of her life. At 48, she thought that perimenopause might be killing her. Thankfully, she has learned how to master midlife and menopause, spending her time educating the 51% of the world born with ovaries and the people that love them. Any partners in the room? Did we scare them all off last night? Woohoo! Educating them and the people who love them about how to make the rest of their life the best of our life at the intersection of aging and midlife, menopause, and mobility. Dr. Wright is a double-boarded orthopedic sports surgeon, entrepreneur, author, speaker, and innovative leader focused on optimizing personal and professional performance at every age. Dr. Wright has served as the inaugural medical director and chief of service in large health systems, building comprehensive programs and departments, and is an internationally recognized authority on active aging and mobility, caring for active people, athletes, and executive performers of all ages and skill levels. Just one more sentence, and then we're gonna get to the questions. In addition to her surgical practice, Dr. Wright is the founder of the nonprofit Women's Health Conversations and membership community Ageless Life. Is it AJLES?
Yes, it's phonetic because we are indefinable.
She's written 5 books, speaks worldwide, and is a media content expert, regularly appearing on national TV shows, print and digital media outlets, and hosts her own podcast, Hot for Your Health.
Do you know what this long intro means? It's just I've been working my ass off since I was 18.
Woohoo! Thank God for us. Okay, I gotta add this little part. Dr. Wright currently lives in Lake Nona, Florida with her husband, 2-time Stanley Cup champion Peter Taglianetti. So cool. And their blended family of 6 children, 2 old dogs, and her 84-year-old parents. So I really, we are here to talk about the myths of menopause. There are so many, and I think we'll be talking about them this whole cruise and how much damage they have done to women's health. But you each have your own specialty. You just heard about their specialty. So in your particular field, I would love to know, what is the most pervasive myth that you see affecting your patients, and how do you handle it? And I'll start with you, Vonda.
How many of you have been to an orthopedic surgeon's office? Right? What happens in my world is because 97% of my colleagues, bless their hearts, are men. And they don't have a uterus or an ovary, so they're not all you, gentlemen, coming here to support. They just lack education. So when you go to an orthopod and 97% of them are men, they don't have the equipment that we have. They're just gonna wanna put metal in your bones, right? And I do that, but here's the myth. That menopause is not only, but most talked about in terms of hot flashes, night sweats, brain fog, the fact that I had to throw my thermometer leg out of the covers just to stay cool, right? The myth is, sorry, I'm such a rambler. The myth is that that's all it is. But the fact is, you will hear later today, 80% of all women will have musculoskeletal symptoms with menopause, and you'll go to the doctor, and they'll probably run some tests, and 41% of the time there's nothing wrong with you. In my colleagues' eyes. What's wrong with them is that they're best friends walking out the door, and it's a rough transition when she does, being estradiol. So musculoskeletal syndrome of menopause is real, and I would, if I were you, encourage all my friends to know that you're not crazy. It hurts, and you're not crazy.
And what do you do about it with your patients?
When a woman comes in, midlife woman comes in with a frozen shoulder, she thinks we're just gonna talk about the frozen shoulder. but then we talk about how old she is and I bet you can't sleep either. And then it doesn't take very long because there is such a need. Doesn't take very long. The orthopod approaching women as a whole person and not just a banged up knee or shoulder. Women are weeping in my office, and I know it's not because I'm frightening. It's because for the first time in their history, they are being seen and validated that you are not crazy and you are not falling apart. And we just need to support that with estradiol, lifting heavy shit, doing zone 2, protecting our sleep, and surrounding ourselves with a cadre of women like you who, listen, I don't even know why there's still a question of what we need. We are the 51%. We own this country, and we need to exert our privilege.
Hey. So one of the things that I think that I've realized as I've gotten to the point where I am menopausal and I see the changes that affect myself is that how much we need to look at the times that people talk about menopause and talk about hormone therapy and address it, and that like you should just grit your teeth and muscle through it. It's just that if you look for help for trying to alleviate some of the symptoms and some of the misery you're going through, it's a form of weakness. And it makes me just crushingly sad for people that they are given this bill of goods that says, if you need help, you can't, and you look for it, first of all, where are you going to find it? But that is a failure on your part when you're really just trying to maintain, not even to make your life better. You're really just trying to hold on to what you've got. So when we look at sexual medicine and menopausal sexual medicine, which some people I was talking to, they're like, that's a thing? Like, yeah, that's a thing. So we spend half of our lives, essentially, with postmenopausal, and we are missing out on that closeness, that release, all the good things that we've experienced in sexual medicine and in being sexual beings. But what can we do about it? We need to protect, we need to maintain, and we need to be proactive. And that's something that a lot of people don't even feel like they need to address because they feel like they've gotten all the information that Corinne is going to tell you about how the little black box on your vaginal estrogen says that it's going to kill you and give you a stroke and make you demented and all those things that we all fear. So we've been driven by fear, and I think that's what I want to try to get that message out there, is that you don't need the fear and you are not weak. In fact, we're freaking strong as hell, and we need to just embrace our strength and embrace the strength that we can spread that message to everybody and bring love back to life.
Kate, just one more question. How do you, I know when I met you, you were telling me about your day like prior to arriving here, and it was like 2 C-sections, a couple of vaginal deliveries, like a hysterectomy.
And
so
2
do you, when you see your menopausal patients, is this like the first thing you ask them, like, how's your sex life? Or do they, because I know they don't bring it up.
They frequently don't. And so I think it's important I make sure that I have a paper, first of all, a paper intake form that addresses it, because a lot of people don't want to bring it up. Mm-hmm. And so if I see it on there, we go through like, hey, how are your kids? And all that, and like, what's your job? Or do you, all the things. Then I say, so are you having any pain? Are you having any dryness? How's it going? We start off with, are you sexually active? And a lot of them will say, actually, no, or kinda. And so that's where we start the conversation is, are you sexually active? Do you want to be sexually active? Is it somewhere, are you good where you are, or is it something that you want to address? Why are you not sexually active? And that is where we usually find the real source of it. And it is hard, and sometimes I'll have to say, hey, we got to get onto this, but we're going to have you come back and let's talk about this. I'm going to give them a rapid fire of these are a couple of things that might help you, just so that they know there are things that can help you. And I say, there's a couple of things that might help you. Come on back and let's get you back in, and we'll talk about that in more detail. But in the meantime, let's do this and this and this, and then come back and do the deep dive.
I want to get time later to ask you more specifics because I think a lot of people are unaware. And I spoke to a divorce lawyer, are you here, from Alabama, who said that so many of her divorce cases that she's dealing with are basically because the guy got Viagra and the woman got nothing. And so we got to get there. But Corinne, I want you to address, my dear colleague, what is the biggest myth of menopause that affects your specialty and your patients?
Well, that's like the topic of my whole presentation, so I'll really dive into that. But I'd say three big points is, one, you just heard how busy the OBGYN's day is, right? And one myth is that the OBGYN should not be the only people caring about this or being knowledgeable about this. When 50% of any doctor's patients, right, if they're seeing both genders, they're seeing women. They're going to see women go through menopause. We all know in this room that it affects every system in your body. It is absurd to delegate it to only the poor, busy OBGYNs, right? Mm-hmm. Now, yes, we have a huge role to play in it, but so do the primary care doctors, and so do every specialist. So that's one, big problem. The other big myth, which we'll address in my talk, is that you are more than your breasts, okay? And the fear of breast cancer is driving all healthcare decisions when it comes to this stage of a woman's life. And that's also absurd. And then it's also absurd that we have an entire medical industrial complex that is profiting and making money on treating all of the associations with aging, right? From, hip replacements, knee replacements, cardiologists, whole list, right? And we say there's medical treatments for those things. We help with the natural process of aging with medicine. Why in menopause is it so awful that we're asking for a little help with science and medicine to help us with the natural freaking process of menopause? Somehow that's taboo, and we should feel shamed that we want hormones because they're unnatural in menopause. It's total absurdity, and I think it's misogyny at its highest form. So I'm a little mad.
Dr. Wright, what is the thing that has helped your menopausal patients the most?
I think that the number one thing that has helped my patients is, number one, I see them. I sit down on a chair and I see them when no one else has seen them because we're midlife, right? So, what was the question?
Well, I'm gonna reframe it to be more helpful to you guys because I think really we have a room, and I've noticed in my conversations over the last less than 24 hours, there's a real different levels of knowledge of what there is available to you as a menopausal patient or perimenopausal patient, or what is driving the pain or the symptoms and how we can fix it. So if you had to sort of give people in this room tools from your toolbox, and including coming to see you or a doctor like you, and by the way, 55 million women in the menopausal age, and there's only a little over 1,000 certified menopause practitioners by the Menopause Society, and there are others out there, but as we know, even some of the 1,200 menopause specialists certified are not necessarily really doing the right thing. That's a math problem that cannot be solved, and I know that some of you out there have said there's no provider near you that will do this, and that's why there are all these solutions online that are popping up, including my colleague, our friend Alicia at Evernow, and at Alloy, and there's a company called MIDI. There really are great options online. But if they could come see,
what do they do in the orthopod's office?
What do they do? And what can you tell this audience?
The number one reason, when I look at I posted this, I look on my schedule, I've got 3 or 4 women in midlife coming in for their shoulder. I don't want to get stuck on adhesive capsulitis because there's so many other things, but it's the comment, right? So for me, I know that her estrogen is walking out the door and it's causing inflammation in her joints. So she'll tell me about her shoulder, but I will revert all the way back to how old are you? I know how old they are in my chart. How old are you? Are you sleeping? Are you having brain fog? So I have to open the conversation. And then they're weeping because no one has seen them, right? And then we build a plan. So I guess it sounds like I do it like you. In a standard ortho visit, you can't spend an hour doing this. But if we want to have deeper conversations, we come back together, and this is the conversation. Treating musculoskeletal syndrome of menopause is estradiol, but not only estradiol, right? Not only. So I prescribe a lot of estrogen at this point for uncomplicated history women. I listen, I teach them. Everybody walks out with a recommendation for Estrogen Matters to prove to yourself with the data that estrogen will not kill you, right? So there's that. And then I go through the things you're going to hear a lot. Mary Claire covers this nationally. An anti-inflammatory diet. We are not going to eat sugar or simple carbs because that will destroy your joints. You must lift heavy. No mamby-pamby pink weights in midlife, please. Number 4.
The pink bands are okay. That was killer.
Yeah. So you must be strong as a bull, but you also may not benefit from high-intensity interval training every single day. Because what happens is too much cortisol. We love cortisol. We need cortisol. It's too much. And you're going to get hurt, and you're going to have to come into Weekend Warrior Clinic on Mondays with me, and you're going to be out for several weeks, right? Right. So that's why being strong is important, protecting your sleep, surrounding yourself with people like you. That's at an orthopedic surgeon's office visit.
That's amazing. Are you the only orthopedic surgeon who do you think who prescribes estrogen?
I am the only orthopedic surgeon prescribing estrogen and a variety of other things.
Yeah.
There's one that I'll show you today. There's only 2 papers in the orthopedic literature about midlife, and we just need more money.
That's
and
crazy.
time, right?
Yeah. All right. Kate, what is the one thing that, like the most common thing you see in your office about sexual health and menopause, and what do you give them? What are their tools?
Oh,
Because I see people like literally taking notes.
Yeah, by far, it's decreased desire. Decreased desire. And I say, that it's not, that's not abnormal. We're not supposed to be living to 80, honestly. We're supposed to reproduce and then be like, see you later. And so it's decreased desire, and I'm definitely going to address that in my talk. And I said I'm going to put out some of my posters because I had way too much to talk about in my talk, and some things over there later. But that's what we're going to do.
I'd say one of the most impactful things I think I can give to women, I think it's important for women to get, is to know their true risks to things in life. Because, again, we're going to talk about this, the fear, their breast cancer risk is their primary driver. I want to know about your personal, individual risk for getting breast cancer. Many women overestimate it. Many women underestimate it. 1 in 4 people in the United States meet criteria for hereditary cancer testing to see if they carry a mutation. Most of them will not actually carry a gene, but 1 in 4 are candidates for it. But less than 20% actually get that done, for instance. It's not because that's going to preclude me from offering you hormone therapy, actually to the contrary. But you should know that risk so we can manage you preventatively. But the same thing goes through for other things. The #1 killer of women is heart disease. So people come in afraid of breast cancer. I don't know if I could treat my menopause symptoms of breast cancer risk. But they're not realizing that they're at a much higher risk of dying of heart disease, right? Or osteoporosis and having a hip fracture and having to go see Vonda for surgery at like 70 and having their lives ruined. Or they're at risk for having a breakdown in their sexual lives and their relationships, or having urinary tract infections and getting admitted to the hospital for, sepsis. I mean, seriously, this is real stuff. So for me, knowing the risks and benefits about your whole life and being able to make an informed decision that's individualized for you, not some generalization buzzword. So, yeah.
So I'm just going to, being the only non-doctor on here, I'm going to make a big pronouncement, and you guys can all talk about it all day long, but the biggest myth about menopause is that if you take estrogen, you will get breast cancer. I just want to overtly say that that is not true. The book Estrogen Matters gives you all the details, but the #1 myth, it came out 20 years ago when a study came out. You guys probably have all heard Mary Claire talking about it, but I just want to be clear, that's the biggest myth, and it's ruining people's lives, and thank God we're all here learning how to combat that and really take care of ourselves. I'm going to go to your questions because I know there are tons, and we'll have more time today, but I want to
Where's our cube? Don't we have a cube? I'm so excited for this cube.
What is
This
the
is
cube?
so cool.
Oh, it's for asking questions. How
Yes.
cool.
I'm gonna have Vonda throw it because I think she's got good muscle strength.
There we go. So, Vonda, you're an ortho, and you talked about musculoskeletal. Are there also issues going through menopause that would impact your nerves in conjunction?
Because you're having numbness and tingling everywhere and, right.
Yeah.
Here's the deal. I cannot think of a tissue in your body that does not care. I could be wrong, but I doubt it. That does not.
I do too. I doubt
Okay.
it.
I cracked myself up. Nerves. Every single tissue in your body has estrogen alpha and estrogen beta receptors. When those are empty, because estrogen has walked out the door, nothing downstream happens. So nerve conduction can go haywire, muscle, all the things you know, muscle, skeleton, ligaments, brain, it's just because estrogen receptors are not being filled, right? So
That's how you got everything. Dry eye, dry ear, dry
well,
vagina.
34, now Mary Claire has identified 75. I
Yeah.
mean, it's life, it's all life. So I don't want you to think that estradiol is the one magic pill. It's not. There's no magic pill for anything, actually, although people are always looking for it. It is a lifestyle, a new lifestyle for you. So, yeah.
Ready?
Tammy from my dinner table
All right,
has a
we'll
question.
go back and then forward. Okay, hang on. Ready?
Oh.
All right. So you mentioned, I'm sorry, a test for cancer screening. Can you tell us or advise us if we're going to a primary care doctor or our OBGYN, what should we be asking for so that we can be well informed?
Great question. It's pretty straightforward. At every annual exam with your internist as well as your OBGYN, because that way if someone's missing out, someone else is picking it up hopefully, they should do a review of your family history. Your family history actually changes. You might get new information, or you might, find out about some cousin, or something new might have happened to your mom. So you should all be really well informed of your own personal, obviously medical history, but your family's history, and you should make sure your doctor's asking for it. And if they're not, you should tell them. And there's actually really clear guidelines that all of their medical societies give them that say that if you have a couple of red flags, some of them being, and remember it's mom or dad's side, would be, red flags for a lot of women with breast cancer premenopausal, bilateral breast cancer in a man, but also colon cancer, GI cancers, uterine cancer, ovarian cancer. And I always, when I take my family history from a patient, I actually ask them some questions. And patients sometimes, will then expand on it a little bit. And it's evolved so much, genetic testing now, that we've got great genetic counselors. Then you can get referred to one and then get your proper panel testing. So I would just say to them, hey, I've heard that, 1 in 4 people in the US meet criteria for at least having a genetic counseling session to just see if, they're candidates for a panel test. And then the other last thing I'm gonna say is that many of you have relatives, moms, sisters who are like, yeah, they had breast cancer and they had that breast cancer gene tested and they're negative, so I don't have to worry. Well, I'm a living proof. I was tested negative for the BRCA gene, never sat right with me, and many years later when I was opening up my own practice doing only GYN and menopause management, I was like learning and I was like, oh damn, there's like panel testing now. This is 2013 and they didn't do the large rearrangement of the gene. So I called my oncologist, I'm like, Middleman, you need to run my test again. He's like, and I was like, trust me. And he calls me 2 weeks later, Corinne, I've got bad news. I'm like, yes, yeah, I know. I had breast cancer at 28. But like I'm BRCA2 and I went around for like almost 10 years not knowing it. And, subsequently my brother's positive and we're gonna test my daughter and, I've got relatives. And so if you think you've been tested in your family, you might need to be tested again. But don't worry, if you carry the gene, we can still give you HRT, and I'm going to talk about that.
There's a question up there.
Over here, over there. Oh, wow.
I'll be right back.
Tammy, we'll get to you, I promise.
Wow, this thing has a microphone. Okay, good. Excellent, so I don't have to stand up. So if your sister had ovarian cancer and she tested something negative, I don't know what. Yeah, we're real helpful, I know, we patients. Should I be tested?
I just always say that if you're unsure, you should always ask your doctor, and you can always ask for a referral to see a genetic counselor. And that doesn't mean you have to have testing, but they can review what's been done and just make recommendations if you would be, eligible for updated testing. And yeah, so just have the conversation. And I'll give you guys resources before the end of this week so you can look it up and show them the paper, because sometimes we've got to teach our doctors, right?
So just one more question quickly to piggyback on that. You're saying that, it's right here, that the panel test is the best option, like if you're adopted and you don't know anything about your family history?
The best test is the one that a thorough review of your background, your medical history with the genetic counselor. There is no one right way. It's just like hormone therapy or anything else, it needs to be individualized. But if you don't feel like you know the right answer, you're not getting the right answer, just keep on pushing them and ask.
Hi. At 45, I had surgery that sent me into menopause, although I didn't know that's what was going on for about 12 years. I'm 59 now. I've been on HRT for a couple years. My practitioner is now kind of going down the road of doesn't know I'm going to have much more benefit because I started so late. And that's really one of the big reasons why I'm here, because I can't imagine going back to that life.
So I'm going to save the full answer for my presentation. You guys are thinking ahead. But I just think this is an example, and all the doctors here this week, we're really going to, I think, double down on this 10-year window nonsense. It's a spectrum. We're going to talk about it. And so I'm not going to, I'm going to save my answer, but I'm also going to just say the dismissal and the gaslighting of women with surgical menopause and premature surgical menopause is of it's huge. It's really impactful. And if you think the average natural menopausal woman is screwed, sprinkle in a little premature, sprinkle in surgery, add a touch of breast cancer or family history of breast cancer, and you're really ignored. So, but
thank you.
Well, you're good. We're going to help you.
I don't know if any of y'all follow Dr. Rachel Rubin, the urologist, fantastic. She, when she's asked about when do I need to stop this hormone therapy, and she'll say, till death do you part.
Hi, I'm Shannon. I'm 48 years old, and I feel like about a year ago I went off the menopause cliff. Like I was healthy, fit, lifting heavy AF weights, and now I'm like, oh, I got that, and I've got that. Not the height sweat, not sweats or whatever. But I guess here's my question: there's so much conflicting evidence. So do you test your fish score or your estradiol, or I still have my uterus? Do I take estrogen and progesterone? If I just take estrogen, is that bad? All of these things. And I feel like I have a great doctor, finally, who's focused on my hormones, despite the Mayo Clinic wanting to take me off of testosterone. They can. But I guess my question is, how do I know that I'm getting the right treatment if I'm still it's not like it is, I do want a magic pill, I really do, but there's not one. And so I'm still, I have a pinched radial nerve. Is that part of the frozen shoulder thing? I don't even know. But how do I know that I'm getting the treatment and I'm on the right track, or that I need to look elsewhere?
Well, when it comes to musculoskeletal, if you have radicular pain that feels like a nerve, you will still get the same conversation with me. However, 41% of the time, we will not find a structural problem for your joint pain or this. That means that a large percentage of the time there is something going on. So I don't know if your nerve is compressed in your neck going down your arm, but estradiol is only one of the tools, because then remember, next we're going to learn how to lift. We're going to do zone 2 instead of killing ourselves. So, I think that's the answer, right?
And I'm going to just add that I think the goal of treatment with hormone therapy is to treat your symptoms and minimize any side effects. And there's an art and a little bit of time to that. And it's okay to amazing.
Or come down and learn about menopause.
Amazing. But so this idea of like dose, and people are like, oh, I can't be on a high dose or I have to be on the lowest dose. No, we all have different absorption levels and our receptors act differently to estrogen. Some of us benefit from testosterone, so really you should really listen to your body, listen to how you're feeling, and it's okay to adjust up and down doses and add things in and try it. And your body will tell you what's working. And we can follow, I'm sure, I'm curious what you'd say, but like we often, if you're not being you don't feel like you're having optimal management, it's okay to see what's your estradiol level at, but really in the end, we're not treating a number, we're treating symptoms.
I think that is one of the things I try to talk about, because there are a lot of clinics that people go to, which there was a need because there's nobody giving anyone any hormones, but they do these panels every 3 months. We're going to do the same panel. We're going to do this, and they're following things, and there are some things that are helpful, but I tell patients, I try to save people money and only do the tests that I think are going to change what we do. And so a lot of times we do just base your changes on symptomatology. And I try to keep an organized list of like, what were they complaining of last time? Let's see if that's better. And I tell them all the time, it's a recipe. You're not slotted into, oh, you're type A, so you get these 3 medicines. So it's always an evolution, and it's really, and I tell them, please message me back if this is not working. If you're feeling like you're crying all the time after 3 nights of prometrium, then you need to call me and let me know, or send me a message because nobody answers the phones. It's always going to be a cocktail or a recipe, I suppose you should say.
Kate, would you say that one of the biggest myths, I've actually heard it a couple times on the boat, is I've had a couple people like, well, I went to my doctor, they took my levels, and I guess I'm not in perimenopause or menopause. And I can't tell you how many people have said that to me here. And
So yes, that all the time. And that's the other, or people come in and they say, will you just check my levels? And they're perimenopausal. And I'm like, well, I would be happy to, but that is not going to really be super helpful to you at this point, because tomorrow they'll be completely different. And so you have to take the time to explain to people, hey, this is what your body's doing. This is why. I had a patient who came in and she was perimenopausal. And so her primary care doctor, bless her heart, at least tried. They did draw some levels, and her estrogen was 800, which normal would be, way, way, way lower than that. And they said they were going to said they needed to send her to an oncologist for a workup to make sure she didn't have an ovarian tumor and all this. I was like, no, she's just 44. So you're going through instead of your normal estrogen levels going up and down like this throughout the month, you're going like this, and then you're going there and up and down, and it's just how your body is responding. And so sometimes hormone levels are helpful, but most of the time in perimenopause, they're not really that helpful.
Hi. At age 49, I was being treated just for Hashimoto's thyroiditis and felt like all of you felt. And all of a sudden, I had a cardiac event. My cholesterol was normal, my blood pressure was normal, but I ended up with a stent and left bundle branch. And I've been told since then I can't do HRT. And I'm just wondering if that's true. So they do have me on preventative blood pressure meds, and it just doesn't make any sense. That's probably menopause created my problem, and there's nothing for somebody like me.
No, there is something for you. Yeah, what, yeah.
Are you on a blood thinner also? No.
Yeah. Okay, that's the wrong answer your doctor gave you, that there's nothing for you. There is everything for you as long as you educate yourself and understand the place you are.
And you have, in life, everything in life is risk.
Give her the microphone.
So somebody like you, again, obviously this is not direct personal medical advice, but I think we would all agree that you deserve a conversation of what the risks are for not doing anything. Perhaps you're suffering and not sleeping and all the things we're all talking about. And what would be the risk of doing something? Like what would happen if we gave you estrogen? Well, I think we'll all agree no one's giving you oral estrogen. You might be someone that we would discuss a very low dose to start of transdermal, FDA-approved bioidentical estrogen with the understanding of what the risk might be to you personally. So I couldn't give you that exact number now, but I think it's a reasonable discussion. We do it every day for every other medication and procedure. When it comes to hormone therapy, it's like a non-starter. When people see Dr. Wright, don't they ask you, you explain, here's the risk of this procedure, here's the benefit, or there's this other procedure you could do, this is the risk and benefit there. You get to choose because it's your body, right? Is that how you do it?
Yes.
Yeah.
Zero, do nothing.
Yeah.
At the end of the journey, and we have all these places in between.
But when it comes to your body and hormones, or women's bodies in general, there's like absolutes, and that's not really accurate.
Listen, I think that when it comes to hormone therapy, people have a very emotional response that's not logical. So there's these emotional responses that clinicians have. If a woman had a premenopausal heart attack and had a stent placed, no one's taking her ovaries out, right? So they're not going to put you in surgical menopause because you had a heart attack. So what is a little bit of postmenopausal estrogen going to do? Nothing. In fact, estrogen is a vasodilator. You can tell that, cardiologist. It's going to actually open up those blood vessels. It's going to allow nitric oxide to come in, which is going to open up those blood vessels. Now, we know that. And so we would probably give you, or I would probably give someone in your instance, because I'm not supposed to give medical advice, but I am, transdermal estrogen. But it's kind of convincing some of these other specialties. So it's the oncologist, or it's the cardiologist, or a lot of times it's the rheumatologist, it's the hematologist, who have this illogical emotional response that estrogen is dangerous and harmful, which is what they've been saying the entire time. But as an internist, when it comes to a lot of these internal medicine specialties, especially something like a heart attack or a stent place, there's these really old ideas that means like you just can't have this, but it doesn't make
Heather,
logical
Simon,
sense.
we have 5 more minutes for these guys to ask questions of the experts on the stage, and you will totally hear from Heather and be able to ask her questions later. Jen, we got the cube over here.
Yes, hi, you can hear me. We've talked a lot about what to do in response to symptoms when you're in menopause. I'm 55 and very clearly menopausal, but I have no symptoms I wouldn't present with, I have come not to my doctor complaining of anything. I wonder if we are reaching a point where HRT will be prescribed for optimal health, just as like a multivitamin or something protective.
Really good question,
Yeah.
really good question.
So I just, a few months ago, it's been maybe 6, talked at a biohacking conference with all the longevity, biohacking, weird stuff. And I immediately posted about the forgotten biohack, which is estradiol. Because for my personal, it's
I love it.
the forgotten biohack. But I hear you. You don't have all the terrible things that your friends do. But the reason that you want to see my patch? I'll show you. No. The reason I do it is actually not for the symptoms that will go away. They will go away in mid-50s. I take estrogen because I value my brain and my heart and all the other 5 or 6 things that we know we're going to die of. So I don't take it for symptoms. I take it for preserving my longevity and health span.
So is there any doctor in the country, though, that Marnie could walk into the office and be like, hi, I have no menopause symptoms, but I would like estradiol because I would like to prevent all these things.
You can, yes, go do that. And when they say, I can't find an OB in Southern Georgia, which is true, I only know that because I moved from Atlanta, but 75 counties have no OB. Like,
Yeah.
where are they birthing their babies?
Yeah.
You can walk into your doctor, and Mary Claire has a nice thing on her website, how to talk to your doctor, right? But then if you can't find somebody to give you what you want,
come to Alloway.
Yes, I was about to say, can we please get it online,
Yes.
right? Yeah.
And, just to point out, the FDA, who doesn't really love women, one of the indications that is FDA approved is for the prevention of osteoporosis. So you could say, well, doctor, I don't have terrible vasomotor symptoms, but I notice on the list there's 2 things that I qualify for. I'd like to prevent the genitourinary syndrome of menopause, and I would like to prevent osteoporosis. And those are 2 out of the 4 indications for HRT. So there's your answer.
That's what you say.
And the biohack, the forgotten biohack.
Okay, somebody's going to write a book with that title. I'm giving it to you right now. It's yours.
Special main event known as the Important Shopping Talk. The show I'm going to be giving you expert advice on all the best shopping attractions for upcoming months, so that you know where to go, what to do, and how to truly maximize your time in port. Now, what you get will come to the show, folks. Well, you're going to get your trusty port maps to help you navigate, access to VIP cards to save you time and money, access to hundreds of dollars in raffles and prizes, including free diamond jewelry, and information you do not
Free diamond jewelry.
I'll be right back.
Jen, you have someone back there. We have like 2 more minutes. Let's just shout over him.
All right. Okay. I'm here in the back. I was 39, hot flashes, 41, full menopause naturally. I feel like every day I have to convince, I'm a nurse practitioner and OBGYN, I have to convince my 4 doctors that I'm real. I have to convince them that 15 minutes is not appropriate. I've had patients suicidal from the symptoms, the brain fog, everything. How do I get past that 15-minute visit? I struggle every day because they don't believe that, especially the guy that's retiring, no offense, but 40 years in the business, brilliant man, but at the same time does not believe that I went through this at 40. And so how do we as providers convince others that this is real, and we have to get past this 15-minute visit with women in the stirrups like you posted the other day. And, that's part of women's health, and you can keep them coming back for more visits, but reality is healthcare is $45 copays and $50 copays for women that can't afford it. And so when I have them for that 15 minutes, I max out every second that I have with them, but I'm struggling with that.
The thing that I've found to be most useful in my 15-minute visits is connecting them with, everybody, when you check out, you're required to have a patient care summary that's sent to you from your EMR. And so I load that up with all the links that I want them to go to, and I say, I know we don't have time to talk about this, but before you come back, I want you to go, and I send them the Audible link because it's really hard to listen to that. You read that. Estrogen Matters. It's a really good book, but I do the Audible. I can do 15, 20 minutes at a time, and then you can go back and listen back.
And you can speed it up a little.
Yeah, speed it up. But I send them as many links as possible, to reach out, it's really hard because the people that, and this is a whole, the people that are giving the 15-minute visit, they don't have, that's what they have. They have 15 minutes, and it's not a 15-minute conversation. So you try to send them to people like Vonda and Corinne and give them their Instagram. I have that attached to all of my little things, and that's got to be the best way. And there are voices out there, and you kind of direct your patients there, but you could tell the providers, you don't have to say it all. There are people out here that are saying it for you. And so that's my best advice is have them, first of all, start following some people, and then also have them know that they don't have to say it all.
And ask to do grand rounds. If you're a healthcare provider here, unfortunately, the 15 minutes is a financial situation. And so I don't want to totally bash all the doctors, right?
Yeah.
There's lots of constraints. Having a Google link that you can send the patients, this is your homework, this is your job.
Oh, I'm sorry.
And our job as clinicians and providers, unfortunately, if we care about this, we have to keep on talking. And it's great what we're doing here, but we got to get into the communities and bring it to the grand rounds and, like, say, can we have coffee? I'll buy you lunch. I want to give you a little spiel of what I learned from the, Menopause Society or whatever.
Okay, we
Jen,
got
is there
one
someone
more.
back there with a question?
Just one more.
Hi, so breast cancer survivor, ER/PR positive, HER2 negative, and so the brain fog and the heart disease and all the things, like we talked last night about vaginal dryness, we hit that, but as far as like those other things, like we aren't candidates for hormone replacement therapy. So I'm
Well-
listening and I'm like, ugh, what are we gonna do?
Well, so listen, I know that that breast cancer survivors feel left out of the conversation. There's 6 million survivors and counting. It's only going to keep on growing. I'm going to touch it on the presentation, and it's really a presentation within itself. So if any of breast cancer survivors out there will kind of carve out a little time on this cruise, and I'll do a mini presentation for just the breast, because it's stuff that not everybody probably wants to listen to. They don't want to hear about aromatase inhibitors. They don't want to do that. But we'll do that. But the easy answer is there's always a choice. Your body, your choice. Yeah.
Okay, I feel like we're like the NFL. Jamie added another minute and a half because of the announcements, so we can still have time to get one or two more questions in there. Yeah. And if anyone's interested in watching the football games in a day or two, are they today? What day is it? Yeah. I might be interested in that too.
Ask the wrong person.
I see someone with a jersey.
This probably goes along with the breast cancer stuff. I don't have any symptoms or whatever. I had like some lumps in my breast years ago, and they did a mammogram, and it was just like fluid-filled cyst. There was nothing like that. But do you recommend yearly mammograms?
Yes.
If you don't have any breast cancer, so
Yeah,
for sure
yeah.
yearly.
Yeah, ACOG and the American Cancer Society and all the leading organizations, baseline at 40, but your breast cancer screening and surveillance should be individualized for you. But for the average risk woman, we're asking you to start at 40 and do it yearly. ACOG says at least every 2 years. We would like every year, really, but at least every 2 years. But there's some where the mammogram isn't the only screening. Maybe they're getting ultrasound. Maybe they're also getting an MRI. Maybe they're starting it earlier. So it has to be individualized.
I try to tell my patients to ask them to do a Tyrer-Cuzick score for them, which is a score that looks at your lifetime risk for breast cancer because it changes your screening protocol. And so if they're not getting a Tyrer-Cuzick score for you, then you may be missing what you should be doing in terms of adding an MRI or adding an ultrasound.
All right, guys, we're at time.
And you could do the score yourself. We can give you the link. Yeah.
So
we'll give you the link. Don't worry. Mary Claire's she's on it. I could tell already.
I mean, so many more questions, so much more to discuss. This is just the beginning of the cruise. There's a lot more. Hi, Pen. Time with all of these great experts, and so. Oh, you have it. Okay. I'm electric. So I just want to say thank you to our panel, to our experts for sharing your expertise. This is really, it's so precious. There's literally only maybe 1,000 people who are practitioners who know all this. So this is just precious. Thank you to Mary Claire for bringing us all together, and thank you to the panel. Thank you. So I still get to be MC for a minute. But, yeah, good job.